In this episode of the Rising Tide podcast, we dive even deeper with Dr. Ali Kaki into the details of his 2021 peer-reviewed publication entitled Loose Regulatory Standards Portend a New Era of Imprecision Oncology. Dr. Kaki is a clinical assistant professor of oncology at Stanford University School of Medicine and is a hematologist-oncologist with board certification in oncology, hematology, and internal medicine. In our previous episode with Dr. Kaki, we discussed the promises and pitfalls of precision medicine and what happens when what gets approved for therapy is broader than the patients assessed in clinical trials, and what happens when the approval encompasses patients with no benefit to targeted treatment. With the growing appeal of targeted therapy, the rapid acceleration of its application to oncology runs the risk of uncoupling medicine from scientific evidence. This particular episode is geared toward anyone seeking detailed, in-depth perspectives about oncology precision therapies. Following the hype rather than the evidence in any treatment can have dire consequences for patients and the entire healthcare ecosystem. We ask what needs to change so that our excitement for precision medicine does not lead to patient care decisions lacking sufficient scientific support. Though precision medicine is advancing cancer care, the progress is gradual rather than meteoric.
There's a lot of hype and excitement, and while progress is being made, I think that the progress in precision oncology is likely much more incremental than what is perceived. There's a study from a few years ago with Vinay Prasad and colleagues in JAMA Oncology where they estimate that only about 8% of patients with cancer were eligible for a genome-targeted therapy in 2018. And while this is up from 5% in 2006, this isn't growing at an exponential rate. It's growing quite incrementally.
Although less than 10% of patients with cancer are eligible for targeted therapy, a number that sounds small, the repercussions when precision is removed from the approval of treatments are significant.
The role of the FDA is to approve medications that have been shown to be safe and effective. Unfortunately, with these broad approvals, we raise questions about how confident are we about how effective these medications are for those who have not been included in the study or have not been shown to have benefit in the study. In both these cases, the broad drug approvals contradicted the principles of precision medicine, where the idea is to identify the specific group that would benefit from a therapy and only treat those patients. I thought that the specific place where this really missed the mark is including, cancers like breast and prostate cancer, which are much more common but have not been shown to have much benefit with immune checkpoint inhibitors. Patients can be exposed rather unnecessarily to toxicity and to cost without little known benefit, or with actually trials that have shown that they don't benefit. To assume that you're going to have some benefit that doesn't even exist in a completely different cancer is the second leap of faith.
Haste makes waste. And with poorly designed clinical trials lacking stratified randomization that includes appropriate control arms, patients bear the brunt of the uncertainty in outcomes that can develop. At the very least, we can openly converse about such uncertainty. Key improvements to trial design, however, would be even better.
The history of medicine will tell you that most things we do are wrong. And so that's why we have to use empirical evidence to prove ourselves that they're right. We have many examples in oncology of promising biomarkers that have gone astray. Unfortunately, I think to do things correctly, things have to be done slowly and iteratively. Tools you could use to sort of try to alleviate some of that uncertainty or make it a bit more, you can feel a bit more confident in your conclusions, is using things like stratification. So making sure you have well-represented populations of the subtypes that you are most interested in. Randomization is key, and something I think that's being lost, especially in precision medicine, is without randomized clinical trials, we have a lot more uncertainty of the benefit to patients. So use stratification with randomization to help make sure you get all the populations of interest.
We need to confront this new uncertainty in clinical science if we stay on this current trajectory of imprecision in oncology.
At the end of the day, you probably can't include every single cancer. So there has to be some, and I think I mentioned this last time, there has to be some decision by patients, oncologists, providers, insurance companies, the society, that if we want to do tumor agnostic approvals, we are comfortable with the uncertainty that accompanies those approvals.
I'm Dr. Megan Garlipow with the Center for Genomic Interpretation, and you're listening to the Rising Tide podcast, where we learn from experts about improving the accuracy and quality of precision medicine and clinical genetics and genomics. Please note that this podcast does not provide medical advice and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Additionally, comments of the Rising Tides guests are their own and do not necessarily reflect the position of the Center for Genomic Interpretation. Today, I am joined again by Dr. Ali Raza Kaki, a medical oncologist in genitourinary cancer at Stanford Cancer Institute and clinical assistant professor at Stanford University. This is the second of a two-part series with Dr. Kaki discussing the promises and pitfalls of precision medicine, potential consequences when FDA approvals extend beyond populations of patients in clinical trials, how to improve selection of patients for therapy, and concepts that all stakeholders should consider for these complex topics. Please note that Dr. Kaki's views are his own and do not necessarily represent the views of his employer. Additionally, some of what we discuss is speculative in nature and/or describes use of treatment that has not been approved by the FDA. In the first episode with Dr. Kaki, we discussed two cases of FDA approvals for drugs in cancer where the populations of the approval, that is, the patients who could end up receiving the drugs prescribed by their clinicians, were broader than the population of patients represented in the clinical trials on which the approvals were based, or were cases of the approvals missing the mark in the patient population. We contextualized these approvals in the broader environment of precision medicine and discussed what is happening currently and what opportunities exist for promising change. In this follow-up, Dr. Kaki and I are going to break open the complexity a bit more. So welcome back, Dr. Kaki.
Thanks, Meg. It's nice to be back.
That's great. So what should a general stakeholder in healthcare, which could be anyone from a patient to a medical director at a community oncology practice, know about what is happening in precision medicine in oncology?
Yeah, I'd say there's a lot of hype and excitement. And while progress is being made, I think that the progress in precision oncology is likely much more incremental than what is perceived. I think I mentioned last time that when we spoke that there's a study from a few years ago with Vinay Prasad and colleagues in JAMA Oncology, where they estimate that only about 8% of patients with cancer were eligible for a genome-targeted therapy in 2018. And while this is up from 5% in 2006, this isn't growing at an exponential rate. It's growing quite incrementally. So at the same time, recently there have been multiple drug approvals by the FDA, where the FDA indication is significantly broader than the studied population, and that this practice introduces a lot more uncertainty into the efficacy and safety of these improved medications.
Okay. So please remind our listeners of some examples of FDA approvals in precision medicine beyond trial population or where they didn't quite hit the mark by providing a general overview of your January 2021 commentary, Loose Regulatory Standards Portend a New Era of Imprecision Oncology, published in the journal Cancer Investigation. And again, some of the motivation you had for writing it.
Yeah, so in this commentary, I reviewed two recent drug approvals by the FDA that I felt the drug approval indications were broader than the studied population or the population that showed a benefit. So the first was the approval of pembrolizumab for tumors with a high tumor mutational burden, the TMB, where the trial population included 10 rare tumor types, but the FDA approval was a tumor agnostic approval that included all cancer types. We discussed last time how I thought that the specific place where this really missed the mark is including, cancers like breast and prostate cancer, which are much more common, but have not been shown to have much benefit with immune checkpoint inhibitors like pembrolizumab. And the second was olaparib for metastatic castration-resistant prostate cancer. And here the FDA label included patients with a genomic alteration in a broad number of genes associated with homologous recombination deficiency, which was the population that was studied in the phase 3 PROfound trial. But the trial only showed that the benefit was mostly limited to those with BRCA1 or BRCA2 mutations, which is what's also been seen in other cancer types. So I felt that in both these cases, the broad drug approvals contradicted the principles of precision medicine, where the idea is to identify the specific group that would benefit from a therapy and only treat those patients. So I wanted to highlight that contradiction, excuse me.
So there's this contradiction, and these patients might not benefit. Why does that matter?
I think this matters because it introduces a lot of uncertainty into the practice of oncology. So, the role of the FDA is to approve medications that have been shown to be safe and effective. Unfortunately, with these broad approvals, we raise questions about how confident are we about how effective these medications are for those who have not been included in the study or have not been shown to have benefit in the study. Therefore, patients can be exposed rather unnecessarily to toxicity and to costs without little known benefit, or with actually trials that have shown that they don't benefit if you include those patients, like in the olaparib example.
Okay, I think that makes sense. So in your commentary, the first approval you discuss is of the immunotherapy drug pembrolizumab, allowing doctors to prescribe the drug to patients with any kind of solid tumor as long as the tumors have at or above a certain threshold of mutations, which in this case is a tumor mutation burden, or TMB, of 10 or more per megabase of tumor genome. The trial this approval is based on is Keynote 158, which assessed patients with tumors with a mutation burden at or above that threshold of 10, compared to patients with TMB below 10. The patients with high TMB responded to pembro more, with an objective response rate of 29%, significantly better than non-TMB high objective response rate of 6.7%. There was no difference between these two groups in duration of response or in overall survival. Can you please remind us of the trial population compared to the FDA drug approval population? What happened there?
Yeah, so the trial population included patients with advanced cancers of 10 different types of rare tumor types. I mentioned them all last time. I won't go through that again. But all those 10 rare tumor types was included in the analysis, identified patients who had TMB high, as you mentioned in your summary just now. We talked last time about how even in the population where there's patients who are TMB high, the ones that seem to be represented in that TMB high subpopulation were overrepresented by cancer that have already shown a benefit to immunotherapy. And importantly, the FDA didn't restrict the population to just those 10 cancer types or just those that had a benefit. It made a tumor agnostic approval, meaning that it allowed all patients with solid tumors who are TMB high to be eligible for this medication. And this just leads to a lot more uncertainty about whether this works in all populations.
Okay. So one of the things I was looking at before this episode was variability in TMB. And I just wanted to make a note that there's also a call for harmonization in how labs measure TMB. And it is, as of yet, it seems not really well understood the role of TMB across different tumor types, kind of adding a layer of really important complexity to that tumor agnostic approach when you're using it with TMB to guide your treatment decisions.
Yeah,
I just wanted to,
one thing I wanted to add there is, as I was even writing the commentary, trying to review the literature of TMB and see patients who benefit, you'll see some studies that mention TMB measured as mutations per exome, some measured as mutations per megabase. And as a oncologist here, I even had to turn to some of my lab medicine colleagues to understand how many megabases are in an exome, and try to sort of make sense of how to think of the different ways TMB has been classified over different studies. And so it's very challenging. I bet even for the people who are in lab medicine or in the diagnostic space, but as a clinician, it's even more challenging to try to digest it all.
Absolutely, absolutely. And it's just another complicating layer that we really need to get a handle on. So if 10 mutations per megabase may be inappropriate for prostate cancer and other cancers, as you describe in your commentary, there was a study that showed that in patients with prostate cancer, if they had a TMB of 70, then they responded, but 53, they did not respond, which is quite a bit different than 10 as a cutoff. So how can this complexity be navigated to better deliver on some of the promises of precision medicine?
Yeah, this is a challenging question. Unfortunately, I think to do things correctly, things have to be done slowly and iteratively. I think that if you've identified a biomarker that is prognostic in a retrospective study, and it may be predictive, then the follow-up work has to be a prospective study to validate its predictive capabilities. And so in the TMB example, you might identify that the ideal cut point for lung cancer is 10 mutations per megabase, but for prostate cancer it's 70 or 5 or any number under the spectrum, and it may be that TMB does not actually have much separation between those who are going to and not going to respond to pembrolizumab for prostate cancer. So you might need to find a new biomarker altogether. So this seems slow and it seems laborious, but this is the only way that we can have confidence that the benefit that we're seeing is actually what bears out. We have many examples in oncology of promising biomarkers that have gone astray. And so I think that for us to convince ourselves that the biomarkers are good without necessarily doing the rigorous work to prove that is dangerous.
Absolutely. And so this next question that I'm about to ask, you just covered a lot of it, but this approval of Pembro is tumor agnostic, meaning that it's for any solid tumor so long as the tumor has mutation load above that certain threshold or cutoff. What trials would need to be done to justify the tumor agnostic approval of Pembro, or really of any drug in this sort of a setting with this sort of complexity? What are the shortcomings of tumor agnostic approvals? And again, Ali, why should we care?
Yeah. So, I mentioned sort of how I would think about, going to develop a new biomarker, but I think the other part of it is, I think that a couple other things I'd emphasize. One is randomization is key, and something I think that's being lost, especially in precision medicine, is without randomized clinical trials, we have a lot more uncertainty of the benefit to patients. So in a tumor agnostic approval, I think that the heterogeneous population that makes it a lot more complex. And I think that tools you could use to sort of try to alleviate some of that uncertainty or make it a bit more, you can feel a bit more confident in your conclusions, is using things like stratification. So making sure you have well-represented populations of the subtypes that you are most interested in. So use stratification with randomization to help make sure you get all the populations of interest. So the Keynote study used stratification with these 10 rare tumor types, but it didn't randomize. So we're still left with a lot of uncertainty. At the end of the day, you probably can't include every single cancer. So there has to be some, and I think I mentioned this last time, there has to be some decision by patients, oncologists, providers, insurance companies, the society, that if we want to do tumor agnostic approvals, we are comfortable with the uncertainty that accompanies those approvals. But because at the end of the day, if your cancer was not well represented in the trial that showed efficacy, then you are taking a leap of faith to trust that this therapy will work for you. Everything that makes sense in biology doesn't actually bear out. In fact, most things don't bear out. So I'll have patients tell me, oh, that makes sense. So I don't know why you have to do this over again, because the history of medicine will tell you that most things we do are wrong. And so that's why we have to use empirical evidence to prove ourselves that they're right.
Oh, absolutely. There should be a journal just called Most Things That We Do Are Wrong. Just be publications based on that. So as a reminder for our listeners, you also discuss olaparib, a PARP inhibitor, in metastatic castration-resistant prostate cancer based on results from the phase 3 PROfound trial, randomizing patients with metastatic castration-resistant prostate cancer and somatic or germline mutations in genes involved in DNA repair. When mutations occur in DNA repair genes, the tumors can be particularly susceptible to PARP inhibition, such as with olaparib. The most well-known mutations occur in BRCA1, BRCA1, and BRCA2, BRCA2. But there are many other genes involved in DNA repair. Patients were randomized to olaparib versus physician's choice of enzalutamide or abiraterone. Patients who got the PARP inhibitor experienced imaging-based progression-free survival of 5.8 months versus 3.5 months in the control arm with the physician's choice therapy, with a hazard ratio for progression to death of 0.49. A pre-specified analysis showed patients with mutations in BRCA1 and or BRCA2 had the most benefit from olaparib compared to the control arm, whereas patients with other mutations, genes like ATM, CDK12, CHEK2, had a null response, so appeared similar in the response to the control arm. And one group of patients, the unlucky patients with mutations in PPP2R2A, experienced a worse outcome on olaparib versus physician's choice. In your commentary, you described this last group of patients with PPP2R2A pathogenic variants as particularly concerning, stating that the suboptimal control arm biased results in favor of olaparib. What made the control group suboptimal, and why is this group so concerning?
Yeah, actually, thanks for bringing this up. We didn't talk about this last time. The suboptimal control group. So, for patients to be enrolled in this trial, they had already progressed on enzalutamide or abiraterone. So enzalutamide is a non-steroidal anti-androgen, or abiraterone, the CYP17 inhibitor. These are, anti-testosterone level therapies for castration-resistant prostate cancer. So for patients to then again receive one of those two medications after having progressed on those medications is not what we would do in the practice of medicine. In fact, 20% of patients in about every one of all the treatment arms had already received both of those medications. So to give those patients again abiraterone or enzalutamide when they've progressed on both of them, that I would consider malpractice. In addition, there are prior studies that have shown that the response rates of enzalutamide after abiraterone can be decent, can be about 35%. But the response rates of abiraterone after enzalutamide is less than 5%. So again, for those patients who were on enzalutamide, progressed, and then were randomized to physician's choice and received enzalutamide again or abiraterone, that would be problematic. So when you consider all of this and then think that a patient with a PPP2R2A mutation, despite all this, despite this poor control arm, still did worse with olaparib, that's a huge issue, right? Because if patients were not on this trial, they would be getting docetaxel or some chemotherapy or some other medication that would actually cause a significant benefit.
Yeah, that gives me chills. Thank you. So mutations in what other DNA repair genes might predict response to treatment with PARP inhibitors, especially in light of the results from the pre-specified analysis that showed null to inferior response in olaparib in non-BRCA1/2 DNA repair genes.
Yeah, I mean, the other genes that were of interest that were studied were, most of the genes that we think of were included in this trial. That ATM, CDK12, CHEK1 and CHEK2. But I think so. I think that in the study we didn't see a benefit with these other mutations. I think that there was good hypotheses to think that they would benefit, or they would respond to PARP inhibitors, but they didn't in the study. I think there is some interesting new science that's being done to think of other ways of defining BRCAness or HRD signatures using functional assays. There's a lot of good science being done to develop new biomarkers. And I think that that's all great, and we need that science, and hopefully then as we identify new biomarkers, we can follow that up with randomized trials with properly selected control arms, so we can confirm that that they have efficacy in the real world.
Okay, great. So when we look at the prescribing information, the packet for olaparib, the FDA approval, metastatic castration-resistant prostate cancer is unique on the label. For one thing, even determining whether a patient with mCRPC is eligible for olaparib relies on 3 different companion diagnostics. In your opinion, should clinicians be concerned about 3 different companion diagnostics being used for olaparib in mCRPC? And what are clinician thoughts on the 3 different companion diagnostics also relying on 3 different tissues, more or less? Blood and plasma are sort of overlapping, and germline versus somatic to assess the genetics and the genomics in this tumor type.
I have to be honest with you. I think that the whole diagnostic arena is very confusing right now. You have, in addition to having multiple different types of tissue sources, blood, plasma, tumor, you have, germline and somatic. You have some platforms that don't report the germline. So there's uncertainty if that's going to be reported out to you. And then you have multiple platforms. You have Foundation, you have Tempus, you have institutional profiles like UW Oncoplex and MSK Impact. I think it's very challenging for even even subspecialized oncologists to digest and keep track of all of the changes. And then I think about those in community oncology or those, who may not be around people who are experts at developing these panels. And I don't know how anyone can keep track of all these things. I think that the science is great. It's very exciting. But to expect an oncologist to keep track of this, in addition to keeping track of the upcoming therapeutics and everything else, it's simply unsustainable.
I absolutely agree. And I think that for clinicians, they're not necessarily aware that seemingly comparable tests across laboratories can vary wildly in quality. It can be really alarming how much variability there is in quality across laboratories. And one lab might be incredibly well versed in cardiomyopathy genetic genomic tests, but then they start a cancer panel and they don't have the same level of excellence, but that can kind of get lost in the messaging.
Yeah, and beyond that, you'll have issues where, as an oncologist, you'll just see how nice the printout is, how straight. Once you get, the science on the back end, there's issues with, and then on the front end also, like, how clear is a report that you're providing?
Yes.
The interpretability of the report is a whole nother issue that also plays into this as well. And so at most academic centers now, they have molecular tumor boards now because of how the complexity with all this. To help sort of unpack this, you need experts to help sort of digest all this information.
Absolutely. So the FDA approved use of olaparib in MCRPC is unique in that multiple genes beyond BRCA1/2 are used for the patient selection. And we've discussed in our prior episode and now how those non-BRCA1/2 patients had a null or inferior response. Yet all of the other types of tumors on the label use only BRCA1 and or BRCA2. What effect could this potentially have on how clinicians are using olaparib in other types of tumors?
Yeah, so I think that this could have the effect that other tumor types, people who are treating other cancer types might also think that ATM or CDK12 or any number of the genes that were included in the olaparib approval could, if they are present in breast cancer or pancreas cancer, they might also try to see if those patients could benefit from olaparib. And there's two errors there, right? The one error is that olaparib should have never been approved for even prostate cancer for those populations because they never benefit. And then to assume that you're going to have some benefit that doesn't even exist in a completely different cancer is the second leap of faith. And so the more leaps of faith we're taking, the more and more uncertainty we're introducing into how we treat our patients.
So what do you make of multiple DNA repair genes guiding treatment in MCRPC? How do these, I'm just going to call them biomarkers here, how do they need to be assessed to understand the potential efficacy in other types of cancer? How could we potentially use ATM in pancreatic cancer?
Yeah, I think that, again, I think you have to prospectively validate that these work for these different cancers. Again, we haven't really showed that olaparib works for these other mutations in prostate cancer. So I would, if I had pancreas cancer, if I had breast cancer, I'd really want to see a study in that cancer that shows that these mutations respond to olaparib or any of the PARP inhibitors.
So I see sometimes language saying that off-label use is permitted by a certain payer if there's peer-reviewed literature supporting it. Trial, but peer-reviewed literature. That could be something like a case study about somebody in another country and the patient had whatever variant, and then they were given this drug and then the patient responded. Is that enough for you?
When I hear that, I'm thinking of vitamin C. We as oncologists need to be better than that. Then I think if we start settling for that, then what makes us any different than a snake oil salesman, right? I think that the promise of Western medicine is to be that we are being rigorous in our assessment, development of modern therapeutics, but also the assessment of the efficacy of them. And so we really need to focus on making sure we develop high quality evidence that shows the benefit in the populations that we're studying. I might sound like a broken record here, but I can't say it enough. Like we have to show benefit in the population that's being studied.
Absolutely. 100% agree. So as our classification of these mutations or the variants, it evolves. Sometimes you'll get a report back that says it's a variant of unknown significance, which means that the evidence out there in the literature isn't sufficient to say whether it's likely pathogenic or pathogenic. And that can be upgraded to likely pathogenic or pathogenic in a gene such as ATM. As this evolves in these genes that guide treatment, how do trials, laboratory genetics and genomics, and assessment need to evolve to deliver the right treatment to the patient?
That is a great question. So, I think that I'm going to mostly talk about it from the trial perspective, because that's how I think about these things, most. And I think that what we can do as oncologists or in clinical trials is we need to find ways to make our clinical trials to be more agile. It shouldn't take months and months to make protocol changes. I think that, there's a fine balance between making sure that you're being cautious in your changes to a protocol to preserve the quality of the science, but to not have so much bureaucracy that conducting the conduct of a clinical trial becomes a barrier to the practice of medicine. So I think that there's work that we can do there. I think there's work we can also do to sort of expand eligibility criteria for patients in clinical trials. I think that there's been much that's been written recently about, representation of underrepresented minorities, other populations. So I think there's a lot of more work we can do there. Less than 10% of all patients end up on a clinical trial. And a lot of that's because, we create these unnecessary barriers. We have too stringent, criteria, that, so that's not directly about the evolving mutations, but I think that like being broader in how we think about clinical trials is the first step, and trying to be agile. And if we find, for example, a pathogenic mutation that we're confident is pathogenic, we could, and there's a trial that's currently underway, then maybe we can amend that trial to also include those patients. Trying to be a bit more agile and finding ways that we can use new tools to sort of allow for that to happen. I think the next thing I'm going to say is a little bit more risky, and I say that because it's not the highest quality evidence, but I think that there is also potential to develop better real world evidence platforms to sort of help capture some of this retrospectively or in real time. And I think ASCO CancerLink has done a great job to sort of build a great platform to sort of help capture structured and some unstructured data from the electronic health record that we can hopefully use to sort of mine and answer these questions after the fact. There's other companies who have been doing this work too, but I think that there are a lot that proceeding in that path needs to be done with much caution, because retrospective evidence is not the same as prospective evidence. And so while I think that there's a lot of value in developing real world evidence platforms, in fact, a lot of my research is in doing so, I think that we have to do so with caution.
Absolutely. I would like to add one additional point. I think that in addition to increasing the agility of clinical trials, we need to improve the patient selection, not just in diversity, but for things like somatic variants. They are really susceptible to false positives. And so if you end up enrolling a bunch of patients who you think have the pathogenic variant but don't actually have it, your trial is, less likely to perform in a way that's significantly different from, a control arm, something like that. And so
is that because of monoallelic versus biallelic loss, or what's the reason for that?
Oh, there are
a number of reasons.
I could do a 2-hour podcast episode on the contributing factors to false positive and somatic variants in particular, even more so than in germline variants. But it's just another interesting point that selection of patients can also improve markedly there. And then subsequently treatment of patients, if we can improve that, then we can actually, in the actual treatment of patients later on, select the best patients for the therapy. So how much patient diversion from trials or more appropriate therapeutics things like that, do you think is happening in oncology as a result of off-label use of targeted therapies and of on-label use when the approval is broader than the trial population?
Yeah, I actually don't know if I've seen any good studies that have addressed this. I thought you might ask me this question. And this is something I worry a lot about, but I haven't seen good evidence of how much this is happening. But I'll give you a couple examples of how I think or where I think this is happening. I mentioned before that less than 10% of patients enroll in clinical trials, and so there's much more work that's needed to sort of increase access. And so when you have other alternatives, that's one more barrier to enrolling people in clinical trials. Other limitations that make it difficult is you have the restrictive inclusion exclusion criteria I mentioned before, and then also the distance from patients. If you're a patient who lives in rural America and you have a choice between getting a drug close to home or traveling to a cancer center for a trial, many are going to pick the drug that's close to home, just because, if I'm in my last, months or years of life, why do I want to be traveling 2, 4, 6 hours or living in a different city just to be on a clinical trial? Not all patients will make that decision. So I think that, I don't know how much diversion is happening, but I think that the solution is to try to find ways to make trials more available close to home, and then not to just settle on off-label drugs. And then I think the other thing that's important is that when it comes to the selection of these versus other, approved therapies, is that we need to be careful in how we are presenting these new therapies. We talked a lot last time about the hype in precision oncology. And so if patients perceive these therapies as being targeted, that they found a mutation, and this is targeting that mutation, they're going to think that this is going to work, much more likely than an untargeted chemotherapy, when that's, that may not be true. There's good evidence already that patients, already can misinterpret what is told to them by the oncologist. There's work that's been done that shows that, when oncologists are talking about palliative chemotherapy, patients will think that they're going to be getting cured with chemotherapy, and so there's a lot that can be lost in translation. And then when you hear, all about these new targeted modern technology, I think many of us have seen the success of so much technology. I carry a computer in my pocket now, so technology has in general worked for us, but unfortunately the same success or progress we've made with other technologies have not been as quick to be realized within biomedicine.
Absolutely.
That's kind of a rambly answer, but
no, I love it. So in your commentary, you write, overall, the goal of precision oncology is to use advanced laboratory methods and biomarkers to better identify patients likely to benefit from a particular therapy. If FDA drug approvals deviate from the populations most likely to benefit, precision oncology is likely to shepherd in a new era of imprecision. Where are we? What is this going to do to patients? What is the long-term outlook of this if we don't get it under control? And again, I asked this last time, I'm asking it again. Do doctors understand this?
Yeah, I think, one thing I didn't mention last time, I think that, I think the lab science, at least my perception of it, now I'm having doubts after our conversation today, has made tremendous strides and is much more precise than it has been historically. But oftentimes in precision oncology, precision medicine, we're oftentimes limited more by our therapeutic options than by the lab science. We understand the human genome, but we don't necessarily have drugs to treat everything, and we probably don't understand the human genome as well as we think we do, but we think we do. But I think in general, we're making progress in oncology. As I mentioned before, I think that progress is iterative and not necessarily at some sort of, precipice of taking off. And then I think that we're often limited by our therapeutic options. That's a big thing. And so I think that the solution there is not to get lost in the science and convince ourselves that the new drugs are better than the old drugs without us proving that with rigorous evidence that supports those conclusions. Even if we find mutations that we're convinced have a role in a pathway, that doesn't mean that if we can't drug that with the drug that we think is not works, that doesn't mean that our pathway is wrong. It could be that our drug is wrong. But so either way, it could be the pathways wrong, it could be the drugs wrong. Whatever it is, we have to produce rigorous evidence that supports our conclusions, supports our hypothesis, and shows that we're actually benefiting patients. Do doctors understand this? I think that probably the treating physicians understand it more than the lab physicians, because the more you're seeing the patients, the more you see sort of what patients are experiencing.
So I think you answered this, but I'm going to ask it again because it's the Rising Tide podcast. How can we raise the tide?
Yeah, so I'm going to say the same three things I said last time we spoke, which is number one, we have to be precise in the conduct of evidence production, which I think precision oncology should start with randomization, and then using other clinical trial tools to help you optimize your population, things like stratification that I mentioned before. Number two, train future physicians to be have critical appraisal skills of the medical literature, so they're equipped to digest the medical literature and counsel their patients appropriately. And number three is remove that heavy hand of private enterprise that exists in biomedicine today.
Great. Ali, this has been such a wonderful conversation. I feel like I could talk to you for like at least 4 more hours about this, a lot of back and forth, but this concludes the second of our 2-part series with Dr. Ali Raza Kaki from Stanford University and Stanford Cancer Institute, talking about precision medicine, FDA approvals, and how to raise the tide. Thank you, Ali.
Thanks, Meg. I'm really excited for this podcast, and I wish you guys all the best as you grow this forward.
If you loved this episode of the Rising Tide podcast, please support us on Patreon and select us on Amazon Smile. The Center for Genomic Interpretation can help your organization identify high-quality clinical genetics and genomics partners, or can help a laboratory identify areas for quality improvement. Through Elevate Genetics, we engage with laboratories, encourage genetic and genomic test validity, and assess test efficacy. Find us at clarifygenetics.org and genomicinterpretation.org. For our listeners following along on YouTube, remember to hit subscribe and to activate alerts for when we post new episodes. You don't want to miss any of these important conversations with leading experts. Together, we can raise the tide.